Hello, am I audible?
Yes, sir.
Yeah. So, good evening, eminent faculties and
One second, sir. Okay, sir. We can start.
okay, it's okay, perfect.
Yes.
Yeah. So, good evening, eminent faculties and guest doctors. Today we have gathered here to attend GU live meetings, which is Pfizer Oncology's initiative for management of urothelial cancer. So, today our topic. Hello. So today our topic for GU Live meeting is first line maintenance treatment of metastatic urothelial carcinoma from clinical trials to clinical practice. So today we have eminent speakers in our faculty list. So I will introduce our faculties first. Then I will hand over the session to Tushar Patil sir. So Rakya, can you please show the disclaimer first? So this meeting is exclusively for invitees only. If you have not been invited to this meeting by Pfizer, we request you to kindly log off. The meeting initiator reserve the rights to block unintended recipients. Video and audio recordings of this WebEx meeting is strictly prohibited. So Rukia, can you start with the introduction slide? Can you make it full screen? So our today's session is moderated by Dr. Tushar Patil sir. Patil sir is consultant medical oncologist at Sahyadri Hospital, Pune. Sir is also assistant professor at Bharatiya Vidyapeeth Medical College and Hospital, Pune. Sir is also associated with Bharatiya Sanskriti Darshan Trust Integrated Cancer Treatment, Curie Manwala Cancer Center, Aditya Birla Hospital. Sir, during his DM oncology training, sir has secured first rank in Gujarat University. As a part of their research, presented a discussion on a clinical profile of gastrointestinal strongly tumors with special reference to imatinib and macrovascular manifestation in scleroderma. Sir has more than 10 publications, and sir has a clinical research experience in metastatic breast cancer as well as relapsed small cell lung cancer. So can you show the next slide? In our esteemed panelist, we have Dr. Varun Nagori sir. Nagori sir is consultant medical oncologist at Marathwada Cancer Center. Sir is also assistant professor in Department of Medical Oncology, Government Cancer Hospital, Aurangabad. Sir is in super specialty training from GCRI, Gujarat. Sir is also co-investigator in a single-arm, multi-center, open-label efficacy and safety study of docetaxel lipid suspension for injection in patient with metastatic castrate-resistant prostate cancer. Sir has published more than 5 papers and articles in national publications. Sir is also a faculty of many local and regional conferences. Sir has secured gold medal in their DM training from GCRI. Sir has also participated in third convention in medical oncology GCRI 2017. And sir has also participated in National Conference on New Horizon in Cancer Biology, Ahmedabad 2018, and secured the second prize in post representation. Next slide. Then we have Dr. Amol Dongre sir as our esteemed panelist. Dongre sir is trained at Tata Memorial Hospital, Mumbai, and has more than 15 years of experience in treating cancer patients. Sir is also professor and head of department of medical oncology at Jawaharlal Nehru Medical College, Savangi, Wardha. Sir is also consultant hemato-oncologist and medical oncologist with the bone marrow specialist in Alexis Multispecialty Hospital, Nagpur. Dr. Amol has been felicitated at international conference at ESCO and also hold a membership, lifetime membership of ESCO, ESMO, and ICON. Sir has a special interest in treating breast cancer, GI malignancy, lung cancer, pediatric leukemia, and lymphomas. Next slide. Then we have Satvik Khaddar sir as our esteemed panelist. Sir is a medical oncologist at SRJ CBCC Cancer Hospital, Indore. Sir has done DM training from Tata Memorial Hospital, Mumbai. Sir also has more than 10 publications on national and international level. Sir has won many prizes during conferences, academics, notably research and travel grant by ISMPO for ESMO Asia meeting, and first prize winner of BM10 Lung Masterclass in 2009. And sir is also affiliated to ESCO, ESMO, and ISMPO with the lifetime membership. And sir is also affiliated. Sir has done also preceptorship program from Dana Farber Institute, USA. So over to Tushar, sir.
Am I audible?
Hello. Yeah, sir, you are audible, sir.
Can I start sharing my this screen?
Yeah, sir, please.
Doing that. Yeah. Are you able to see the screen?
Yeah, sir, screen is visible, sir. So make it the full screen, sir.
Yeah. So I think today's discussion is about frontline treatment as a maintenance in metastatic urothelial cancer, from whatever data we have in clinical trials to our clinical practice. How do we take this forward? More and more number of what we say as urothelial cancers that we are coming across, and I think we have seen a remarkable increase in the survival with the use of various sequential treatments, either chemotherapy or immunotherapy. Uh, Maintenance strategies becoming the most important, say, or part of treatment for almost all cancers, lung cancer, breast cancer, and urothelial cancers too. So Bavencio avelumab is a human anti-PD-L1 immunotherapy which engages both adaptive and innate immunity, and it's indicated as a first-line maintenance for urothelial cancers, as a monotherapy for first-line maintenance of treatment with adults with locally advanced or metastatic UC whose disease has not progressed after the platinum-based induction chemotherapy, as a first-line treatment for renal cell cancer in combination with axitinib for adult patients with advanced RCC, and as a monotherapy for treatment of adult patients with metastatic Merkel cell carcinoma. The first and only immunotherapy to demonstrate an OS in first-line setting for locally advanced or metastatic urothelial carcinoma when used as a maintenance treatment. I would like to ask Dr. Varun, how do you see your patients progressing from first line to second line or subsequent line? Like in terms of the number of patients that you have in the first line, how many progress to second line to take the second or the third line subsequently?
Yeah, very good evening, everybody. Sir, as you say, for metastatic urothelial cancer, usually the patients are in the elderly group, which I have seen in my practice. That elderly group performance status is not very up to the mark in all of the patients. So if the patient is having good performance status, then we start with the platinum-based therapy, with platinum or carboplatinum doublet in the first line. Eventually, all of them, they progress with a PFS somewhere around 8 to 10 months is what I've seen. But out of the patients who take first line treatment, in my practice, there are only 40 to 50% of the patients who are good enough or maintain the performance status to take the second line therapy. So probably what I have seen or what I have observed is not most of them make it to second line therapy in a very comfortable manner. Only 40 to 50% of them can make it to second line therapy as of now, what I have observed.
That's true. So I think age, the stage of the disease, comorbids, and the amount of exposure to the drugs like cisplatin and subsequent toxicities because of that, all these have a say in how many patients progress to second line treatment. And rightly said, around 40 to 50% of them would go into second line. I think third line would be hardly 10 to 15% only, not more than that. What does you say, Amol?
Yes, sir. I totally agree what he said. I mean, in fact, I would say rather hardly 20 to 30% will progress to will go on to second line, and maybe 10% to third line.
Correct. So I think the first line is where if we at all we hit hard, and if the patient is really responding, we can increase the survival by doing some maintenance strategy. That's the best time to do it rather than doing the treatments in the second line or the third line, where very less patients are likely to reach. Dr. Satvik, what would be your definition of platinum eligibility or cisplatinum eligibility in particular?
Yeah, good evening, sir. So
Fine.
usually, what we take is creatine clearance of for cisplatin, creatine clearance of less than 60, performance status of 3 or 4, then peripheral neuropathy and cardiac dysfunction, pre-existing cardiac dysfunction. We would avoid cisplatin because of hydration and other requirements. And completely platinum ineligible, I would say a creatine clearance of less than 30 and a PS3 or 4. I would say, suggest to avoid carboplatin also.
Okay. So how many patients in your clinical practice in the metastatic urothelial cancer do you do cisplatin and carboplatin? A rough figure.
Cisplatin very rarely, because majority because of the performance status, age, or the creatine clearance. So, and I prefer carboplatin usually in metastatic setting. And so majority of my patients go for carboplatin only, not cisplatin.
Okay. Okay. And have you ever encountered patients with borderline creatinine, like somewhere between 40 to 60, where you may still be able to give, because it's a weekly dosing of cisplatin, it's not high doses.
Yeah. So then I also consider the age. If it's on the lower side, maybe around 55 or 50 years, then I would be comfortable in giving cisplatin.
Okay. So I think this is where all the textbooks do mention cisplatin as the preferred treatment, but in clinical practice, because of so many reasons, including performance status of the patient, cardiac or comorbidities, and the borderline creatinine clearance, most of us do go ahead with carboplatin instead of cisplatin, at least in the metastatic setting. Maybe that's a way. From my side, many times, whenever there is a borderline creatinine clearance or around 50 or so, I start with cisplatin, but as the creatinine clearance starts dropping, maybe then I convert into carboplatin. Is what I do. Usually, the preferred drug still remains cisplatin as per the book. Amol, do you have anything else to say about this platinum eligibility or platinum eligibility?
Basically, what Satvik said is very right. But if I mean, I would agree completely that create clearance of 60. Many times we see the create clearance in the range of 50, and still would be more inclined to give cisplatin based on other factors. Like
many other factors.
Yeah. I mean, just talking about even head neck, many of the patients do have creatinine clearance around 15, but still we give them cisplatin. So it's just not the creatinine clearance, but other factors we need to consider. And if you ask me, like, what percentage of patient is cisplatin eligible, so I would say around 50 to 60 are eligible, even, in a urothelial. Cisplatin ineligible, yes, another 20 to 30, and platinum ineligible is hardly 10% is what we see in a practice.
True. So at least carboplatin can be given to most of the patients, even if
exactly.
Very true. So yes, the performance status, poor performance status, very low creatinine clearance, peripheral neuropathy, heart failure, and a performance status which is 2, but creatinine clearance is less than 30. This is what audiometry. Do you all perform? What is the status baseline audiometry or a follow-up audiometry?
To be very frank, no. I mean, I have not performed on any of the patients on at least urothelial carcinoma.
Yeah, I think we are doing more into pediatric, I think, but
exactly.
Adults, we are not doing audiometry routinely. Yes, I think more so because metastatic urothelial carcinoma, the survival itself may not be that prolonged. First, second is that the amount of cisplatin that we will be giving for 4 cycles, maybe, or at the most 6 cycles, may still be within the reasonable limits of what we want to give. Not so for pediatric patients where very high doses of cisplatin are used, and we regularly need to monitor their audiometry. So, Varun, what is your routine OS that you're observing with chemotherapy in your practice in the first line, second line?
For metastatic urothelial cancer, for with the best of the performance status, and if the patient is platinum or cisplatin eligible, then also what I have observed is even with a good tolerance of platinum doublet, the maximum that I have seen is somewhere around 12 to 15 months, not more than that. As of now, 1 year, maximum 15 months somewhere, not more than that I have seen.
Right. So I think first 4 to 6 months, most of your patients would achieve almost 80-85% patients would achieve control. but more
good
than
initial
2/3 will lose that control within 9 months time, and by that time they progress, most of them become ineligible for further treatment because of various reasons, performance status, comorbidities, or maybe rising creatinine, so many things. So leading to a very poor survival of 12 to 15 months. And in the last, I think 8, 10, 12 years, 15 years, nothing has changed in this survival. So in urothelial carcinoma, I think there were hardly any progress which was made in terms of chemotherapeutic agents or other agents. I remember a drug called as, I think, vinflunine came sometime in 2009, 2010, and the rapidity at which it came, the same rapidity it went away. So hardly anybody using those drugs nowadays. They still hover around platinums, gemcitabine, paclitaxel. Sometimes some people use ifosfamide or pemetrexed if the patient's condition allows, and so on and so forth. So we've been playing around with cytotoxic chemotherapies only. No targeted therapies evolved till date for urothelial malignancies. And avelumab just, or the immunotherapy in general, has been a boon in such patients. So survival has been poor conventionally. So in unresectable or locally advanced or metastatic, what is your preferred approach in platinum eligible patients? Dr. Satvik, how do you take it forward?
Sorry, voice was not. Can you repeat the question?
Yeah, so in this unresectable class of locally advanced metastatic urothelial, what is your preferred approach in a platinum eligible patients? How do you go about?
Yes, so I target 4 to 6 cycles of platinum doublet chemotherapy, preferably as discussed, either cisplatin or if not, then carboplatin based.
Yes.
At least 4 cycles, but maximum 6 cycles, and then observation.
Then
if
observation.
response.
Amol, what do you do in your clinical practice?
Pardon, sir. Pardon, Dr. Tushar.
Yes, so metastatic urothelial cancer, platinum eligible, you put them on chemotherapy. How do you go about? How many cycles? And after a finite number of cycles, what do you do for these patients?
No, so basically, as everyone said, the same thing, doublet chemo we use, and I do assess after 3 cycles, 3 to 4 cycles, and if responding well, maybe a max of 6 cycles is what I give.
Correct. Varun, do you have a same opinion or different opinion?
No, absolutely same. So, for now, as of what we have practiced is a platinum doublet. If they are eligible for 4 to 6 cycles as per the tolerance, and then observe.
I think what we have seen in clinical practice is also the tolerance. So by the time the 4th cycle comes in, the cytopenias and the thrombocytopenias, anemia sets in quite well. Every cycle, the patient needs some transfusion after the 4th cycle. We've seen this in many other malignancies where gemcitabine, carboplatin, or gemcitabine cisplatin is being used. That these cytopenias do set in, and they take a longer time to recover because of probably harsher marrow suppression because of the gemcitabine drug. So yes, our approach has still been the same. First line chemotherapy, 4 to 6 cycles, and then observe and give what we say as second line chemotherapy after the progression. Or now with the advent of these treatments, possibly we can do some maintenance, either continuation maintenance of chemo plus IO or a switch maintenance from a chemo to the IO. If we have a wait and watch approach with first line platinum based chemotherapies, where the response rates are close to 50 to 60% and disease control rate of 50 to 80, but median OS remains around 12 to 15 months. 50 to 80% of these patients achieve control, but the OS is limited because of the chemo resistance that comes in. That's the median OS with cisplatin 14 to 15 months and carboplatin based 13 to 14 months, all of them being almost the same. How do you find the role of IO in such first line setting, and how do you take it forward? Amol, I would like you to ask this question, answer this question.
Well, so since we know the response rate is great for the initial few months, but then eventually each and every patient does progress in the span of another 6 months. So definitely there is a role of IO, even though we didn't have trials supporting that, but yes, the whatever like the data we have now of IO is definitely going to benefit these patients. What we need is a good PFS, a good DFI, and which we get if we add up IO in this.
Correct. So I think disease biology will define, and that's what is the basis of all those trials where they've been taken, is that only responding patients have been taken into the immunotherapy trials, and responding in the sense non-progressing patients, and they are the ones who possibly would be a better subset to continue in the IO trials. And
So, Dr. Tushar, I mean, I don't understand why people look at OS. What we need in a metastatic setting is a DFS or a PFS.
correct.
So,
So if you can achieve OS is the best thing, but PFS is definitely what we should look for, at least that particular individual drug.
Absolutely.
Yeah, and usually that's what the regulatory agencies also look into. Some of the agencies are actually looking into only response rates and clinical
Yeah.
or disease control rate and duration
Yeah,
of the.
because the moment the patient metastatic, we tell them clearly that it's not curable. We are trying to
Correct.
prolong your disease. So when we
Correct.
say we are
Correct.
trying to prolong our disease, means we actually try to prolong it only. We never say that OS, I mean, we know he's gonna progress sooner or later.
Yes.
So I don't know.
So,
Yeah.
so OS still remains the gold standard, but PFS is something which is the second, what we say as the best standard that we are looking for every drug.
Absolutely.
So with coming to this, we have these trials, IMvigor 130, Keynote 361, Danube, with various what we say immunotherapeutic drugs in combination with the chemotherapy, with the IMvigor trial of atezolizumab showing no significant difference in the OS at the second interim analysis. The Pembro trial had a negative outcome as for the immunotherapy arm, and the IO doublet of durvalumab and tremelimumab had a negative outcome, did not meet the OS as per the 2020 data. This is the atezolizumab arm. As you see, the drug atezo plus chemotherapy versus placebo plus chemotherapy. 3 months difference. Hazard ratio being 0.83, and the p-value is non-significant for the OS. Looking at the keynote again, pembrolizumab, the hazard ratio being 0.86 and the p-value being 0.04. The 12-month rate 62% versus 56% for the OS. If you see the PFS also, again, the atezo and compared to the placebo, 8.2 versus 6.3, hazard ratio being 0.82. And for the keynote pembrolizumab, the PFS being 33% versus 20.9% at 12 months, the value being significant. So OS did not actually, but PFS, there was some betterment in the immunotherapeutic arm when they were combined. And the Danube trial actually had 3 arms, 1:1, durvalumab single agent, durvalumab plus tremelimumab, and standard of chemotherapy arm. And these were the patients with untreated, unresectable, locally advanced metastatic urothelial carcinoma. More than 1,000 patients were taken into this trial. As you could see, durva is compared to immunotherapy. The median OS is 13.2 versus 12.1. The hazard ratio is 0.99. So, and median duration of response 9.3 versus 5.7 months. The second is the switch maintenance. So this strategy of combining chemo plus IO probably did not work for most of the drugs that were going through this trial. The second strategy of switch maintenance, which our avelumab drug trial, Javelin Bladder, showed, is probably the only phase 3 study demonstrating significant OS in the urothelial metastatic setting, where chemotherapy followed by IO maintenance for non-progressive disease with the avelumab drug, there was a significant benefit in doing a maintenance versus not doing a maintenance for the OS. Again, another trial, GU14182 of chemo followed by IO maintenance for pembrolizumab, there was a benefit, but it was a non-significant benefit as compared to no maintenance. So probably the concept of having a maintenance IO after your chemotherapy gets over in patients who are responding does make sense, at least in the metastatic urothelial cancer. So with wait and watch policy, possibly we are looking at progressing disease, only 15 to 20% patients who are coming for the second line treatment, dropping their performance status and making them ineligible for the second treatment. With a continuation maintenance of IO plus chemotherapy, probably it did not show a good result in terms of OS for most of the drugs, atezolizumab, pembrolizumab, as well as the IO arm with durvalumab and tremelimab. The switch maintenance, it was the only approach possibly which showed or translated into the maximum OS. What is your take on this, Dr. Satvik? How do you interpret the chemo plus IO not working as compared to switch IO working?
Yeah, so this is something very interesting that combination is not working, but the switch maintenance
Yes.
is working. So could be the disease response as discussed.
Correct.
Because this requires disease and which is handled by chemotherapy alone, and then the like maintaining the response is done by the immunotherapy, and having additional immunotherapy during chemotherapy might not give additional responses for the disease. So I
Correct.
guess
Correct.
that is the concept.
I think one more thing would be that I think most of these trials would not have done prior. They must have done it as a part of their trial, but would not have randomized based on the PDL1 status. Possibly. How do you utilize your PDL1 data in your clinical practice for metastatic urothelial? Amol or Varun?
Yeah, I mean, I've never done a PDL1 testing for urothelial, to be very frank.
Acha.
It's just, yeah.
Okay.
So even though I've used in urothelial, but I've never done PDL1 testing per se and then started.
Varun, what is your take on this?
Same here, sir. I've never done for urothelial cancer. PDL1 testing probably did not find any uh, motive to do so, and never tried doing PDL1 in urothelial cancer as of now.
Okay. But as a recommendation, what is the NCCN guidelines say? That PDL1 should be done or PDL1 should not be done?
Only probably in patients who are completely platinum ineligible, where we want to try single agent immunotherapy, probably pembrolizumab is where I feel the data says that the benefit with PDL1 positive is what I remember.
Correct.
Only in the patients who are completely not eligible for platinum, there probably is a role of doing PDL1.
Correct. So I think for cisplatinum ineligible patient, you give it for where you want to do the drug upfront, maybe when you do PDL1. Or patients, if you are not at all eligible for any platinum, then probably PDL1 is regardless. We can do the drug, immuno-oncology drug, without doing the PDL1. So this is what is the recommendation also. With this, we move on to the next slide where it shows how this trial and everything is being. So this is the different strategies versus platinum or carboplatin eligible, where patients are showing non-progressive disease with platinum doublet, and IO versus placebo, as we can see, avelumab and pembro, where avelumab did show a better OS. The second is cisplatin eligible patients randomized into IO plus chemo or chemo. And as we said, all these drugs in immuno-oncology did not do anything better than the chemo arm. And patients who are cisplatin eligible or randomized into IO plus IO or ADC or chemotherapy. Again, the immuno-oncology drug failed. So out of all the drugs studied, probably only avelumab as a maintenance strategy did show some improvement in the survival. Maintenance therapy introduces a treatment approach for patients who have a response or stable disease after the first line treatment. It can be given shortly after the completion of induction, whose disease is not progressing. Unlike the existing approved PDL1 inhibitors for advanced UC, patients may be treated with first line maintenance avelumab regardless of the PDL1 status, and hence it is not a prerequisite. So that's how the flow chart goes. First line, you do platinum based therapy, then you do a maintenance, and then the patients who fail, you do a second line treatment. This offers an alternative option to the wait and watch policy in patients who are progression free after the first platinum based chemotherapy. It also introduces a treatment approach that aims to prolong the clinical responses and maintain the patient's quality of life. Preclinical data shows that IO therapy with this that complements the mechanism of action of chemotherapy. In addition, IO maintenance therapy may reinforce and sustain the clinical benefit of the chemotherapy. It prolongs the responses and maintains the quality of life. Both these parameters being satisfied with the use of maintenance avelumab or maintenance immunotherapy. Coming to this, little bit about the Javelin Bladder 100 trial. It was a phase 3 trial, randomized, open-label, parallel arm at 370 locations, 700 patients taken up, locally advanced or metastatic urothelial cancer carcinoma. The patients who had completed their chemotherapy and were non-progressing were randomized to avelumab plus best supportive care versus only best supportive care as a first-line maintenance treatment after the completion of chemotherapy. Avelumab 10 mg per kg every 2 weeks versus best supportive care. Primary endpoint being OS, and of course secondary endpoints being PFS, OR, time to response, disease control, safety, tolerability, quality of life issue things. So the scientific rationale of avelumab was there was an activation of the primary T cells and reversion of exhaustion, tumor cell leading to tumor cell death, deepening of tumor responses, and induction of innate effector functions. If we look at the baseline characteristics, the median age was almost 68 years, 76% male and 24% females. Most of the patients had a very good performance status of either 0 or 1. The location of metastasis, even for almost 55% of the metastases were visceral metastasis. And for first-line chemotherapy, we had gemcitabine, cisplatin, gemcitabine, carboplatin, or either cisplatin or carboplatin switch kind of a thing, 50, 42, and 6%. With this, if we look at the primary analysis of survival, the cutoff date being 2019, 21.4 months versus 14.3 is the median OS. The hazard ratio for this being 0.69, and there was a 7.1 months absolute improvement in the median OS in patients who received the avelumab. If you look at the long-term primary endpoint of this OS, which is 2021 June cutoff, 23.8 versus 15 months. Better than the previous recorded 21.4 months. So at longer interval, probably 8.8 months improvement as compared to 7 months survival improvement in the survival. If we see the OS benefit in PD-L1 positive patients, the median OS is not estimated as compared to 17.1 months for this population. And at the end of 21 months, 2021, in June 2021, as we can see for PD-L1 positive, 30.9 months versus 18.5 months. So definitely for patients who are PD-L1 positive, there is a higher OS which is observed as compared to PD-L1 negative or overall population. Varun, do you have anything to say on this slide as regards PD-L1 status and the responses to immunotherapy?
As expected, as extrapolated from previous trials also, sir, definitely PD-L1 positive population are supposed to respond better to immunotherapy. But as we can see, these patients also have responded better or have a, in general, better survival with chemotherapy also.
Yes, I think that is the takeaway point from this slide, that regardless of what is happening, they do have a better survival in the PD-L1 population.
The anti-tumor, what do you say, capability of the immune system probably is upregulated. So these are innately probably better responding patients to chemotherapy also. And if PD-L1 targeting agents are added, then it is definitely going to add to benefit.
Yes. Satvik, your take on this? What do you?
Yes, definitely. I agree that although the patients who are PD-L1 positive are responding better to immunotherapy, but the control arm is also responding better. So in general, they do respond. I would interpret this as, although we do not do PD-L1, but if we have done then and if we are giving immunotherapy, we can prognosticate the patient that we expect a better response. Although the choice of whether to give or not immunotherapy does not depend on PD-L1, but it's just that we can hope that they will respond longer.
Yes. True. So OS benefit was seen across all the subgroups, whether the type of chemotherapy, age related, response to chemotherapy, the number of cycles that was given, PD-L1 status, overall population, all the parameters, the avelumab maintenance did fare well as compared to the best supportive care only. The patients treated with Bavencio continued to achieve a longer median PFS compared to those treated with only best supportive care. There was a 1.7-month improvement in the median PFS in patients receiving Bavencio and 3 to 0.4 months in median PFS at the data cutoff in 2021. So, with this, we come to this. Would you like to perform the PD-L1 testing before starting avelumab as a maintenance? What is your take on this? Again, Amol, would you like to do it?
So as I said, even though we are not doing it, but yes, once we do it, we will be more confident in telling the counseling patients and relatives that yes, the benefit is definitely there and it is more. Apart from that, I don't think there's any other benefit.
Probably more rationalizing of our
rationalizing,
of our thought process. Patient also would be more convinced that from a 24 months, our survival jumps to just 33, 34 months. So that's how happens. So that's how probably convincing becomes more easy. So would your treatment approach be different if this patient has achieved either CR, PR or stable disease? Again, I think the question has been answered with the advent of the immunotherapy maintenance. So with this trial, we saw the OS irrespective of the prior response to chemotherapy, whether there was a partial response, whether there was a stable disease, or there was a complete response. So non-progressive disease and progressive disease were the only two factors which mattered. Non-progressive disease, all these patients did really well with the maintenance treatment. Complete response, the median OS which was achieved is 39.8 months versus 26 for patients with best supportive care. With partial response, it was 19 versus 12. And with stable disease, it was 22 versus 14. So I think taken together, non-progressive disease that did really well. And that's what the initial inclusion criteria was. Again, for the PFS also, it's the same regardless of the status. Can we consider avelumab irrespective of the chemotherapy offered? If this next slide gives an answer to this, yes, for all patients, including patients who are on gemcitabine, cisplatin, or carboplatin, or switched from cisplatin to carboplatin because of one or the other reason, avelumab maintenance did fare well as compared to only best supportive care. As we can see here, the OS for cisplatin 25 versus 16 months, the PFS 4.6 versus 2. For carboplatin again, it's 19.9 months, which is the OS. So OS and PFS benefit with avelumab first line maintenance occurred irrespective of the first line chemotherapy being used. Now coming to a very, very crucial question, how many cycles in your clinical practice do you recommend to your patients? Satvik, you the first one to answer this.
Yes, sir. So as I mentioned earlier that maximum 6 and we assess response after 3 or 4 cycles of therapy. And I would try to give it at least 4, but maximum 6 cycles.
I think that's the prudent answer. 4 cycles is the minimum, and if the patient can be stretched up to 6 with reasonable side effect profile, probably that's the best to go. And for a maintenance, you're starting your maintenance. Varun, when is the time that you start your maintenance? After if at all you plan to do the patients on maintenance avelumab after your completion of chemotherapy.
So yeah. Am I audible, sir?
Yes.
Yeah. So for a very practical purpose, don't have that practical experience in urothelial cancer as of now for maintenance. But if I do plan to start some maintenance after completion, probably I would wait for say 4 to 6 weeks for all the chemotoxicities to resolve, the patient to regain the physiology, and after 4 to 6 cycles, so there is a comfort that needs to be established with the patient, and then I would start. Probably I would wait for 4 weeks, somewhere around 4 to 6 weeks, and then start the maintenance.
Ideal time. The trial people waited for 4 to 10 weeks. That was their criteria. 4 to 10 weeks, but yes, 4 to 6 or 4 to 8 weeks is what would the patients require for coming out of the side effect profile from the chemotherapy. As you can see from this slide, the number of cycles did not matter. 4 cycles, 5 cycles, 6 cycles. The survival still remains the same for both for the avelumab arm as compared to the best supportive care. Here again, this question has been answered. So no one starts immediately, less than 4 weeks. We usually allow the side effect of the chemotherapy to wane off, and that's the time, ideal time to start. And again, if we see the interval to start the immunotherapy, 6 to 8 weeks, 8 to 10 weeks, it did not matter. So up to 10 weeks is what is recommended. 4 to 10 weeks is the ideal time where you can start your immunotherapy drug for these patients. Avelumab first line plus best supportive care versus best supportive care Asian population. So this is something which interests us about the Asian population, and we have a data because Asian population was included. There were 147 patients from various Asian countries, and the primary endpoint being OS and the other endpoint being PFS or OR. Again, you see the parameters well balanced in both the arms. Close to 40% in Bavencio arm were PD-L1 positive and 27 were negative. If we see the first line treatment, it still demonstrated a prolonged OS as compared to best supportive care, 28 versus 18 months. And at 24 months, 60.7% versus 43.5% patients is the survival. So Asian population also benefited almost the same way as the entire population. Longer term follow-up continues to show a prolonged PFS with this avelumab drug alone in Asian population, as we can see from the graph. Treatment-related AEs, Amol, can you point specifically towards any AEs that you have encountered with avelumab?
Well, not per se specific, like none of my patients do have actual whatever. I mean, what side effects we encounter in other IOs, fortunately not with avelumab. I mean, I really don't know what's the reason for that.
Yes, I think very true. When I, as a PI, had also done a trial on avelumab for the avelumab drug. This was, I think, 4 years or 5 years back. So that time also, avelumab did not have any major concerning toxicities, treatment-related AEs, but these are the ones which have been enumerated: pyrexia, nasopharyngitis, constipation, anemia, hematuria, arthralgia. Okay, the routine ones which are there. So they occurred in almost 31.9% of the patients in the avelumab arm, any grade event. If the Asian subgroup analysis is done, so this drug demonstrated as a maintenance a new standard of care for patients with advanced urothelial carcinoma whose disease did not progress with the first line chemotherapy-based regimen. The primary endpoint of median OS was 25.3 months from the start of maintenance versus 18 months with best supportive care only. There was a 26% reduction in the risk of death versus best supportive care alone with in Asian patients with a hazard ratio of 0.74. Bavencio first line maintenance treatment led to numerically longer time to the end of the next line therapy in Asian subgroup compared with best supportive care alone. And safety and tolerability of Bavencio first line maintenance was consistent with the overall population that was seen. So this is again the AEs which were the treatment-related AEs which led to the discontinuation of avelumab happened in 11.9% of patients. Death was attributed by investigator to study treatment toxicity in 2 patients, that is 0.6% in the Bavencio arm, and 1 death occurred due to sepsis after 11 infusions of Bavencio, and the other due to ischemic stroke 100 days after the single dose of Bavencio. So this was the data about the treatment-related AEs which were seen with the avelumab. There were no grade 4 or grade 5 immune-related AEs which occurred. High-dose steroids, that is 40 mg or more of daily prednisone equivalent, were administered following immune-related AEs in 9% of the patients who were treated with avelumab. One patient had a AE after more than 12 months of treatment with Bavencio that led to death attributed to immune-mediated nephritis by the patient. So that could also focused on the long-term treatment-related AEs that may occur in some of the patients. How would you like to continue your Bevacizumab maintenance? Varun, if at all you decide to do Bavencio maintenance for your patient after chemotherapy, how long is the time that you would continue your maintenance?
So probably I am not very practically aware of it, but till the time probably patient is tolerating with no unmanageable side effect profile, probably say at least a year as per the data. We can go up to 1 year for this thing maintenance.
Okay.
And if it's rating, we can go more, but it probably would come with practical use of the drug.
Correct. Amol, do you have any experience with in this setting?
No, well, I don't have much experience with the maintenance, but yes, 1 year seems logical, and I mean everything financially also and per se. So I would like to continue for 1 year as a maintenance, even though I don't have any explanation why just 1 year.
Okay, Satvik.
Yes, definitely. I would agree that 1 year is as per the guidelines, but yes, or till an acceptable toxicity.
Yeah. So I think for immuno-oncology, I think majority of the drugs, there is a data of up to almost 2 years and even beyond. But 2 years is many times. In the renal cell, I think we are using for 2 years at least whenever we try to use Keytruda or other drugs. So here they're trying to depict how many patients took, were the ones who were cross 6 months, 12 months, and about 24 months. As we could see, 50% of the patients took it for more than 6 months. 28% for more than 12 months, and almost 20% were exposed for more than 24 months. The median duration of treatment was 25.3 weeks for this avelumab maintenance. And if you see the control or OS at 12 months was 71%, even at 24 months it was 50%, and 36 months it was 36%. For patients who were PD-L1 positive, I think at 36 months there was a 45% OS which we had. So unprecedented, and these values are important in knowing how PD-L1 status did matter for avelumab therapy. So OS in patients with more than 12 months of avelumab did. It was not reached. And even investigator assessed PFS, it was almost 26.7 months. So again, the question comes of how do you sequence? With our knowledge, possibly now more enriched with what the data shows for avelumab maintenance, we would like to interpose this avelumab maintenance or immuno-oncology maintenance somewhere after your chemotherapy or non-progressing disease. And if there is any progression, unacceptable side effects, toxicity, that probably is the time to switch to a second line treatment. Your take on this, Satvik?
Yes, so if you're using first line, so immunotherapy avelumab in first line as a maintenance, then definitely on disease progression, we either have the choice of conventional chemotherapies like taxanes or targeted therapies, FGFR inhibitors, if you are doing the NGS testing.
I think disease biology also plays a very important role.
Yes, definitely.
So I have a patient who is right now 82. He was 79 when they started. He started as a loco-regional disease, said no for surgery. After chemotherapy, we gave him chemoradiation. After 1 year, he progressed to become metastatic. Again, metastatic in the sense locally recurrent, not metastatic, true sense, but not willing for any surgical approach. So we put him on a second line chemotherapy, which he did well. Then, because he was not able to take immuno-oncology drug, we had to put him on. We maintained him on carboplatin, single drug carboplatin. He took that carboplatin for almost a year, more than a year. Then he progressed again not willing for any, and locally progressed, no metastasis. Again, not willing for any local therapy or not willing for anything. He said, "Sir, give me another set of chemo. I'll take that." So he's been on and off chemo, and he's now 82, 83. So 3.5 years on treatment and doing really well. So there are patients who choose their biology and they go by that and still continue to respond at every moment. Subsequent therapy for these patients, as we can see, 53% of the patients in the best supportive arm receive PD-L1 or PD-1 inhibitors in the subsequent line. That's what is there. This trial did not allow a crossover. So this is the exploratory analysis, survival by type of second line treatment. Median OS was similar in subgroups of the patients with and without second line treatment. This is our guideline which shows what all do we have for patients as a treatment and as a maintenance option for metastatic urothelial cancers. Subsequent therapies across the trials have shown many drugs, including immuno-oncology, some of the immuno-oncology drugs, some chemotherapeutic drugs, some only chemo, some combinations, some IO combinations also, which are being used. Survival goes further with the right IO at the right time. That's very important. Important message to be given across. As we can see, if we have a first line chemotherapy, which gives us a 3 to 5 months period, and there is after a treatment free interval of 4 to 8, 10 weeks, we start with avelumab maintenance as the first line. We possibly get 30 months of survival that we are looking at, median survival that we are looking at. If we are using immuno-oncology as a second line after first line platinum containing chemotherapy, then we probably get 16 to 18 months of survival. If we are using with combination with first line platinum chemotherapy combination, again 16 to 17 months as what we see as survival. If we are using for immuno-oncology drug only as a first line monotherapy for patients who are ineligible cisplatin ineligible or patients with a PD-L1 tumor positivity, again the average survival is around 12.3 versus 18.5 months. If you're using a doublet immuno-oncology as a first line treatment, possibly the survival is at around 15.1 months. So chemotherapy with a break followed by avelumab possibly gives us the best outcome in terms of overall survival with least side effect profile. It has been shown across various populations, especially also for the Asian population. It has been true where the data is similar, and yes, it's a very strong data. A long-term follow-up of this trial, more than 2 years, continues to show prolongation of OS and PFS with the avelumab arm, both among all randomized patients and also with the PD-L1 positive tumors. OS at 2 years was 49.9 months in the avelumab as compared to 38.4 months percent in the best supportive care arm. The 2-year PFS rates were 23.4 versus 7.1 respectively. The long-term safety profile of this drug was consistent with the previous monotherapy studies, and no new safety signals were identified. OS was prolonged with avelumab first-line maintenance despite a high proportion of patients treated with best supportive care alone receiving a subsequent anti-cancer therapy, either avelumab or best supportive care. These results further support the recommendation of the avelumab maintenance as a standard of care for patients with advanced urothelial cancer that has not progressed with first-line platinum-containing chemotherapy. Long-term safety data and the high percentage of patients on treatment at 2 years indicate the good tolerability and feasibility of the regimen as the treatment until the progression. So I think the message is loud and clear. These are the patient segments and the new standard of care which can be applicable in patients. Cisplatin eligible, go for cisplatin based chemotherapy followed by avelumab maintenance. Ineligible cisplatin, go for a carboplatin based followed by avelumab. And totally ineligible patients go for a IO monotherapy. And that's what I think we have been using in our clinical practice too. This is about Bavencio dosing, 800 mg infusion over 16 minutes every 2 weeks. Pre-medication adjustment to the infusion rate can help manage infusion reactions. Pre-medication with an antihistaminic with paracetamol prior to the first 4 infusions of Bavencio. Patients with so What is the pre-medication that you are using routinely for IO drugs, Satvik?
Yeah, so during the routinely I'm not using, but if the patient is developing reactions, then only I'm using Avil.
Okay. Acha, okay. For our practice, we are using Avil as and a paracetamol also as a routine IO for any IO. How many times have you used steroids for side effect management of IOs? Even short course steroids.
Yeah, definitely. If the patient has developed, I have some patients who have developed skin reactions, then I've used to mitigate the immune-related events, but not as a pre-medication.
Correct. So pre-medication, I think it's strictly no, but
Yes.
that's for patients. So one of our patients recently developed continuous fever after Nivo and ipilimumab, and third day it started and it went on for almost 7 days. For a melanoma, we were giving him, and we had on the 6th day when all the reports were normal and his fever was not settling. We gave him a short course steroids and we gave it for 3 days only, and his fever subsided. So sometimes you may have to use steroids to mitigate the infusion related, not infusion related, but some side effects because of the immuno-oncology drugs. I think this is about the abbreviated prescribing formation, and we all know that it's a Merck Pfizer alliance.
So, Dr. Tushar, I just wanted to know one thing. Like you have
Yes.
mentioned your patient about IO, toxicity and use of steroids. So,
Correct.
even one of my patient has Nivo. After Nivo, he has a bad gastroenteritis. I mean, I knew it is just IO related, and he's still on maintenance Nivo. So, what I did is what I'm doing is whenever I give him Nivo, I just start him on steroids for 5 days. So I don't know whether I'm doing good or bad, but that is how his diarrhea responded. So are you tapering steroid whenever you're starting to, are you tapering it or you're just discontinuing? I just want to know of the track.
No,
I'm sorry.
we discontinue. It's a very short course that we are giving. So 4-5 days only at the most. At the most.
4-5
We
days.
just discontinuing. There is no tapering in that.
Absolutely. So every time I give him Nivo, I give him 5 days of steroids, Omnacortil, just to take it, and then he's right, all good. Otherwise, he started having diarrhea and all. So that's
Well,
it's been discussed now that there's no contraindication to give steroid. IV takes also sometimes.
No. Sometimes you can. For severe reactions, you might have to consider using even during infusions.
Yeah. Yes.
And to answer your question, if your patient is responding, then you're doing the right thing.
Yeah. Thank you. Thank you.
So I think with this, we have discussed everything about the avelumab maintenance that it offers for metastatic urothelial cancers as a first-line maintenance after the chemotherapy. And hopefully this was a good discussion that happened. It was nice talking to all the panelists. I'm sorry, Dr. Varun, Dr. Satvik, Dr. Amol. Nice to connect with all. We'll soon meet. We are conducting the Best of ASCO in Pune this time. So hope that all of you will be there for the Best of ASCO in Pune. We hope to host you.
Dr. Tushar, what are the dates for Best of ASCO in Pune? What are the dates?
23rd to 25th of June. So immediately post ASCO
23rd to 25th?
23rd to 25th of June. Yeah.
25th. Okay, that's great. Yeah.
Correct. So I think from our side it's over, and it's over to Pfizer team for the next proceedings.
Yeah. So sir, thank you very much, Tushar sir, for excellent moderation, and Varun sir, Amol sir, and Satvik sir for worthful discussion. So today we have, sir, more than 25 attendees across the region who have enjoyed this scientific feast, sir. And sir, now we are opening floor for question and answer session, sir. If from anybody, if any question is there. So I think, sir, there is no question. So, sir, I would like to also tell you that with Bevenzio, sir, we are offering trade scheme of 1+2. So every purchase of every vial, sir, patient will get 2 vials free of cost, sir, during the therapy, sir.
Okay. Great.
Yes, yes, sir. And sir, on the occasion of World Cancer Awareness Month, sir, we would like to take a we would like to capture a pic of all the faculty members, sir. So, if possible, sir, can you open the camera, sir? All the faculty members, sir.
I'll do that.
Varun, sir, Amol, sir, Satvik, sir, all, sir.
They have done it.
Yeah. Hello. Varun, sir, is visible. Satvik, sir, Amol, sir, Tushar, sir.
I am visible.
Yeah, sir. So, Rukia, can you take the screenshot? The
Yes, sir.
entire
One second.
members.
Yes, sir. Taken, sir.
Taken. Hello.
Yes, sir. Taken, sir. Yeah.
So, sir, on the behalf of Pfizer Oncology team, sir, once again want to thank you all, sir, for joining and sparing time and joining this meeting, sir. Sir,
Thank you.
Yeah, thank you.
Yeah.
Thank you.
so, sir,
Have a great Friday evening, Saturday evening, and have a great weekend.
good night, sir.
Good night.
So, sir, sir, any last take-home messages from each and of faculty members on, Avlimab, or anything closing remarks from all faculty members and moderator, please? Yeah.
I think maintenance is very important in improving the survival for metastatic urothelial cancer patients. And as an immuno-oncology drug, Avelumab has shown that the maintenance has been really very effective, preserving the good quality of life, hardly any side effect profile, and at the same time giving us much needed benefit, what was not present in the last 10-15 years, what could not be achieved.
Thank you so much, sir. Sir, Varun, sir, Amol, sir, Satvik, sir.
Satvik, sir.
Yeah, sure. So definitely, this was an unmet need, and I think we all anyways counsel, and we should now counsel more and more patients to get the benefit of the immunotherapy as a maintenance.
Dr. Varun, sir, would you like to give any last take home, sir?
Yeah, definitely. So this is definitely a very hopeful avenue for cases like metastatic urothelial cancer, where probably we haven't seen much of newer developments or newer addition to our armamentarium as compared to other diseases. So probably this is a very hopeful avenue to increase the unmet need of PFS and OS for this disease. As much as the financial constraints and other things are concerned, probably the use of a maintenance would definitely increase in future as more and more patient support programs and other activities increase. So we'll definitely like to counsel the patients whenever feasible for taking the maintenance in the first line setting.
Thank you so much, Dr. Varun, sir, Dr. Tushar, sir, and Dr. Satvik, sir, for such a nice virtual treat for all the delegates. And definitely they have understood the nuances of managing urothelial and metastatic renal cell carcinoma. Thanks for all your inputs and insight that you have given during this webinar. With this, I think we can sign out. Thank
Good
you.
night. Good night, everybody.
Good night.
Good night, sir.
Thank you so much, sir. Good night.
Thank you, sir. Bye, sir.